the gastric pouch. And the reason is that if you're going to perform a subsequent procedure, the gastric wall is just much more amenable to hold the stent in position with a lower likelihood of the stent migrating. So if I have to work from the jejunum, I take that into account when I decide to proceed or not. So now we'll use the GIEQs system. We have chosen the 20 millimeter by 10 millimeter hot GIEQs system, which is very, very useful in this setting, as it will help us to quite easily, either now or at the subsequent session, pass the duodenoscope through the stent. So we have a good position now. We will prepare the GIEQs stent by connecting it to diathermy. There are a few settings that one can use. I think there's a preset setting already installed that we will use. Peter, maybe you can tell us what the preset setting is.
Yeah, so I think it's on AutoCut, and it's effect 5, and we use 100 watts. Okay. So it's basically the same as for a cystogastrotome.
So no endocut?
No endocut, no.
So with that in position, I think what I sometimes see people do, which may make it difficult, is when you press against the lumen, don't try to press too hard, too quickly. It should be a much more gentle push as you insert and pass it through. So we're going to start now. We're going to already start with the coagulation and then gently push through into the lumen. So there we can now see the GIEQs in the lumen. I hope that's very clear to everyone. Into the lumen. We will now remove for the first placement, the first distal flange placement. That will be the next plan of action. So there you can see the distal flange starting to open. I'm going to just make sure that it sits well enough, and we can continue to open the flange. And there you can see the distal flange is nicely deployed. In the next step, we will pull that back with a 20 millimeter. It's important to know not to pull it back too much. And we will then lock it. And in the final phase, I will deploy the stent already in the working channel of the endoscope. I'm doing it very gently, because if you do it too fast, there may be a sudden movement of the stent and displacement of the stent. So now the stent is fully deployed in the working channel, and now I can push the stent out of the working channel. So now it's a decision time, and I would like your opinion on this, Tom. We've got a patient that requires an ERCP, no doubt about that, based on the symptomatology. We've got someone that is not in any way septic, does not have cholangitis. We have successfully placed the 20 millimeter stent, and now we have to decide if we're going to go for the ERCP now or wait 2 weeks to come back to perform the ERCP. What would your preference be?
Here now, I'm looking at what you're doing, and I would be very keen in seeing you proceeding, but for the sake of the patient and also for the sake of training, I always say to my trainees, don't be a cowboy in endoscopy. So I fully agree that there is no need of trying to dilate here the jejunal and trying to do the ERCP all at once now, because the risk is much more elevated, much more increased when you do it all at once as compared to a two-step procedure. So I fully agree, although I admit that I would like to see you continue, but I think for the sake of the patient and for the sake of training, etc., it should not be done in a single procedure here. There is no need to do so.
I absolutely agree. I think there are too many reasons not to proceed. Patient is stable. We have a good position of the stent. We will allow the stent to open fully and a mature tract to form. This will happen in the next 2 weeks, and then it will be easy to perform the ELCP. And if the ELCP has been performed, Peter can come out, remove the stent, and close so that the patient does not need a third procedure just for the removal of the stent.
Would you mind showing us a larger endoscopic view to have an idea of the placement or the position of the stent as compared to the pouch and also as compared to the alimentary limb? Is it the alimentary limb is not blocked because of the flare of the stent?
No, I think that you can see the alimentary limb is, we can easily show it there towards the right side. It opens up towards the right side, so it's not affected by the stent placement. But even if it is, it just means that your food will continue to pass through the axial stent in the meantime until you remove it. So it's not a major issue, but you can see that it's quite easy to, now that I inflate it a little bit more, that you can see that food can go either way. So I think that that's perfectly fine.
Very nice presentation, Peter. There is already a question here from the audience, and the question is, why gastrojejunostomy and not a conventional uncovered duodenal stent?
Yeah, so of course a duodenal stent has several disadvantages. So most of the time you will occlude will the stent occlude the ampullary orifice, which is not a big issue, but if the patient would do a biliary obstruction, you don't have a very easy access. Secondly, if you use an uncovered stent, after 1 week it's very, very difficult to remove the stents, while here luminal opposing metal stents, if there would be a problem or an issue, you can easily remove them. And finally, I think the functional results. So as of my experience and also what is published in some case series in the literature, I think that the functional results of a luminal opposing metal stent gastrojejunostomy are far better than that of a duodenal stent. In fact, the patient after placement of these lumps is able to eat normally, and I mean really normally, and mostly the day after the procedure already. While for the duodenal stenting, my personal experience that you will alleviate the gastric outlet obstruction, but you will never achieve such a functional result.
And there will be tumor ingrowth after a couple of weeks already.
Also. The disadvantage, of course, of the axial stent is that it is more expensive. And if you would misplace the lumen opposing metal stent, you don't have an access to the jejunum. So this means that it's an unavoidable surgery for this patient. She now has a relapse with the disease. The problem is that it's a large tumoral mass in the abdomen, so it's not possible to operate her, but this abdominal mass is compressing the bile duct and also the duodenum. So she has a bile duct obstruction and a gastric outlet obstruction. So today we are going to try to solve both problems at the same during one procedure. I'm going to demonstrate the technique of an EUS guided gastrojejunostomy to alleviate the gastric outlet obstruction, and also of an EUS guided choledochoduodenostomy to drain the biliary duct. So the first step in the gastrojejunostomy is to go with a colonoscope or a therapeutic gastroscope to the level of the obstruction in the duodenum. So here is the pylorus. And you see here already the mass that is compressing the duodenum. So I'm gonna use a cannula now first bring my scope in the desired position, or my fluoroscopy in the desired position. So yeah. So you see on the fluoroscopy image that there is a loop, probably around traits, that is very near to the stomach. So I'm going to aim for that loop to create a gastrojejunostomy. This is a catheter, and with this catheter I'm going to try to pass a little bit into the duodenum, to advance a little bit in the duodenum, yes. So and now we advance the wire. Yes, you can advance the wire. So I'm able to get a little bit with my endoscope inside the duodenum. And you see here that it's really over a very long segment that is compressed by the tumor. Yes, so you see that the wire is now advancing towards the angle of traits, and it's also easy for me now to pass the catheter up to that level. Okay, so we advance. So yeah, put a little bit of traction on the wire while I am advancing the nasobiliary catheter. Okay, so you see my catheter following the wire. Yes, so I'm now likely at the level of trait. Yeah. Okay. So now I'm the position of my nasobiliary catheter is very good. So it's below traits. I'm gonna ask to inject a little bit of contrast now. You can remove the wire. Yes, perfect. Okay, yes. So we are, yeah, that's enough. So, and now, so we will leave the nasobiliary catheter of 7 French in place. And we will start to fill the segment that is very close to the stomach wall with water. And I put some blue in the water so to make sure that if I create the gastrojejunostomy that I see that the blue liquid is flowing into the stomach. And this is, of course, a confirmation of a good position. Ja, ik ga hier. So the next step is to visualize the expanded small bubble loop.
Tom, maybe can I ask you a question? Because while we were doing the procedure with Schalk, so you are one of the, experts in entero ERCP. Would you still consider to do this in patients with a gastric bypass, or would you consider now this edge procedure as the first line procedure?
I think it depends on what the indication of the ERCP is. If, for example, it is a suspicion of an ampuloma, for example, I cannot treat an ampuloma with my introscope coming from below. So there I would advocate the use, the placement or the creation of edge with the lamps and then try to do a conventional ERCP or even ampulectomy. However, most of the cases of indications of ERCP after gastric bypass are common bile duct stones. And there I think it is safer, quicker, because it's a single-step procedure to take your introscope, go up, go all the way down to the Roux-en-Y and go up to the papilla, do the sphincterotomy, take out the stone, you take out the endoscope, and the patient goes home. So I always advocate try it first with the endoscope. My success rate in gastric bypass patients is 3 out of 4. And what we usually do, we discuss this with the patient on beforehand. in case of failure, and the failure is always not reaching the papilla. Once you're at the papilla, you can always do the ERCP. It's sometimes difficult, but you can always do the ERCP with the enteroscope. But when you don't get to the papilla, then we take out the enteroscope, and during the same procedure, under general anesthesia, of course, we create the edge. So, and then we don't wait 2 weeks. We only wait for 1 week. 1 week later, we do the actual ERCP. So I think it's still safer and even quicker to use an enteroscope to do, let's say, a simple ERCP in a patient with a gastric bypass. And in our unit, it is only in case of failure of the enteroscope, then we switch to the edge procedure, which in our center is also a 2-step procedure. Only in case of really urgent procedures or urgent indications, then we will make it a single-step procedure.
Okay. Yeah. Okay. I think we can conclude the discussion here. So, yeah, we still have some time left, but I think it's okay to close the session. So I would like to thank everyone, Tom Oreels, Helena, also for participating in this discussion, and everyone who made this first GIEQs Day a success. Thank you very much.